When we think about choosing therapy and sequencing in the context of newly diagnosed myeloma, in my mind, there continue to be sort of two groups that patients are broken down into. The first group is the fit patients, and I'm going to avoid the use of the transplant eligible versus transplant ineligible because I think that depends on where in the world you live. And so really focus on the fit patients where I think a quad induction, most commonly with anti-CD38 plus an RVD combination, really does represent the initial standard for 4 cycles of therapy, collection of stem cells, and then consolidation with either MEL-200 or MEL-140, depending upon the age of the patient and the frailty. I think that the question about maintenance therapy for a standard risk patient, the Perseus study suggests that the use of Lendera was optimal. I think that there are other data sets, including our own, that suggest that some patients may be able to just use Len alone, and that allows you to save Dara for first relapse if that's where you want to go. So I think those are discussions and controversial issues. When we talk about the frail patient, I think that the question again is, does a quad become the standard as we saw in the IMROS study or as we saw in the BENEFIT study? And my concern with those two studies is that they really excluded frail patients. And so for me, and with a frail patient, I really consider Dara-Lendex to be the standard and continue to use that even after they achieve a remission as sort of ongoing maintenance, if you will, dose adjusting the Dex, stopping the Dex, and dose adjusting the Len and the Dara at once a month until progression.